Hi, I'm Ralph Ruban, the Baxley Professor and Director of the Department of Pathology, and it's a pleasure to be here this morning in the Mario Molina studios. I absolutely love history. I love Hopkins history, and I love Johns Hopkins. And it's only appropriate that we're here today to celebrate an important part of Johns Hopkins history. I've been here almost 4 decades, and I can tell you one of the proudest moments I have for Hopkins is the way Johns Hopkins, the faculty and staff, responded to the COVID-19 pandemic. I'm so pleased to have today with us Karen Carroll, the Director of Microbiology, and Heba Mustafa, the Director of Clinical Virology. Heba, Karen, welcome.
Thank you, Dr. Rosen.
Looking back, is there anything in your training or your studies that led you to anticipate this pandemic? Karen, let's start with you.
Okay. So I think for years, the Centers for Disease Control warned that a global influenza pandemic might occur. So I think in some ways we were all, braced for that eventuality. In my tenure here at Hopkins, we've dealt with surges of a variety of other infectious diseases, such as influenza H1N1, the original SARS, Zika virus. And then finally, through our affiliations and training with the biocontainment unit here at Hopkins, we also had the opportunity to drill in anticipation of the next global pandemic.
Great. How about you?
Yeah, I think same. Both my medical training and my research training, actually, which focused on virology, prepared me that we are always facing outbreaks. I guess when we thought about outbreaks, we were kind of always thinking about influenza. However, when it comes to coronaviruses, actually the possibility of a spillover was always there. It was always a question of when. So to me, it was not really surprising that there was an outbreak or a pandemic. What was remarkable was actually the speed by which the pandemic spread globally.
That's it. Fascinating. It leads me to my next question. And Heba, I'll start with you. What were your thoughts when you first heard of the outbreak of COVID-19 in China?
I was very concerned, specifically when it was pneumonia of unknown pathogen. So the word unknown to me was very, very concerning. I should acknowledge the Chinese group, though, that they were quickly able to identify the pathogen. So I was actually teaching a coronavirus lecture at that time, and I was talking to the students about the pneumonia of unknown etiology, and it was actually surprising that the students didn't even hear about it yet. But to us in the lab, we were actually very, very concerned. Then with the progress of the situation, to us in the lab, it was then the main concern was actually about how we would be able to diagnose and prepare and so on.
Thank you. Karen, what about you? What are your thoughts?
Yeah, so similarly, I thought this was going to be perhaps an avian influenza or some other virus that had made the leap from an animal to human, similar to the original SARS. And I was actually quite concerned that, similar to the original SARS epidemic, that we would soon see cases in the United States. And we needed to be prepared for that.
And so, Karen, maybe I'll direct the next question to you. How did you feel? What were your kind of when the first suspected case hit Hopkins?
Yeah, so the first case, the first person under investigation was admitted to the biocontainment unit, and we were alerted by Drs. Garibaldi and Maragakis. And I remember thinking that if this virus was going to take off, that we would need more than the biocontainment unit to address it. We would actually probably need to take advantage of some of our units that had the negative pressure rooms. And to their credit, Dr. Maragakis and Garibaldi were already concerned about that. So they were communicating with us and prepared to handle what was soon to be a major global pandemic.
Thanks. What about you? How did you feel with that first case?
I can feel it again now.
I know.
So this was actually February 3rd, when we had that patient who traveled to Wuhan. He presented with headache and the chills and the fever, and he was influenza negative. And I remember exchanging texts and emails and phone calls with Karen and Dr. Lisa Maragakas, trying to figure out what exactly is needed and the extent of the time actually we needed to figure out what are the CDC criteria of patients under investigation and what exactly we need to do to have the testing done in the CDC, and what are the logistics of the biocontainment unit activation. So it was actually a lot of uncertainties. And as Karen actually highlighted that it was like, to us, the question was like, it's not gonna, like, the biocontainment unit will not be enough, but also the testing is not gonna be enough. And this was like a very complicated procedure to have a patient diagnosed. And we realized at that time that the testing and the diagnostics would be actually our only way to control and isolate and diagnose efficiently and timely. And we started at that time actually to work hard on this.
Well, that leads me right into my next question is, now today we can go to the grocery store buy a whole swab of tests. What was the status of testing when that first case hit, and can you describe that process?
Yeah, so the testing was only offered at the CDC at that time, which we can all now think that this was not sufficient, was not efficient. So they had a strict criteria of the patient's clinical definition of patient under investigation. And there was some paperwork that like each provider or each lab had to fill to justify why testing is needed. And the capacity was very limited at that time. And they tried to kind of outsource this testing to the public health labs. And also this was not sufficient and was very limited. And at that time, and I don't want to like really talk too much about this, but the regulations limited our ability to offer testing in-house. So I should say that diagnostics were insufficient, were really not enough to cover what we needed if it's for patients with symptoms or contacts, which was actually very significant because it contributed to significant community transmission.
And wasn't there a problem with the CDC test? That I thought that one of the three probes used actually was not on target.
Yeah, right. That's correct. And they ended up excluding one of three targets that they had in their test.
Karen, what about your thoughts on that, the early testing?
Yeah, so I mean, I have to agree with Heba. I think early on in the United States, there was very limited testing. I think in one of your subsequent questions, we'll sort of get into the timeline that we followed, but it was very concerning that we didn't have a confirmatory test, even for cases outside of Maryland. And all of us felt like we were in the dark in terms of what it is we were dealing with, and actually.
And so then the pandemic didn't just hit Hopkins; it hit, of course, the whole country, and supply chain issues quickly became a major issue. Can you describe, maybe Karen, I'll start with you, some of the supply chain issues you faced and how you dealt with them?
So, I mean, if we get back up a little bit in terms of the challenges that we faced, to echo what Heba said, we knew in early February that we were going to need a test. The sequencing of the virus had been done, and laboratories were very anxious to be able to test our patients. And so we actually filed an application once the CDC posted that they had a kit available. We actually, in February 7th, that's how early we tried to get a kit. or reagents to do testing here. And we sent a letter. I remember distinctly working with Heba and Steve Dahl. We submitted the letter. A week later, we were told that since we were not a public health laboratory, that they would not release reagents. And so then we turned to our state health lab. And the state health lab basically said, there's a problem with the CDC kit. We can't really share anything with you at this point. So the state lab was also, in a little bit of trouble in terms of whether they were going to be able to test those first cases. So but by the end of February, the state lab was able to go live with their testing, but they were limited to 100 a day. Can you imagine, for the entire state of Maryland? And so we knew this was not going to be adequate. So Heba came to me and said, can we make our own test? And I said, yes, but we don't have reagents. And so there was this mad dash to get genetic material. And luckily, a company called Altona had primers and probes, and we were able, through the generosity of individuals at the University of Texas Medical Branch, to acquire the genetic material that we could use for our controls. And then eventually the state lab did give us did let us know which of our patients were positive, and we could then verify our test. And Heba, I'm going to defer to you to talk about your team, because it really is an amazing story, and I want to get that on camera, and just how the molecular lab validated a test in basically 4 days. So
yeah, how about
you should continue the story
to go through that timeline?
Yeah.
To really lay it out. So it's early February. The test has to be sent to the CDC. It's not. They don't have enough tests, and it's not working. You've applied for authorization to do the testing here at Hopkins. But there's supply chain issues. So if you can take it from there, that'd be great.
It was really a very challenging time. We really tried hard, as Karen mentioned, to have the CDC assay here, but they didn't, as she mentioned, authorize us as a public health lab, so we couldn't do that. But then really developing our first assay here, which was Altona reagents based, and I have to acknowledge them because they were really working very closely with us. And then my fantastic team, so we really worked as a team. Once we received the reagents and the genetic materials from UTMB, we were together in the lab, and I really would like to thank Missy, Kate, Craig, Mamia, Liz, Linda. We were together in the lab, pipetting, troubleshooting, assessing the reproducibility of the assay. Really, 3 days, 24/7, we actually got it done. And additional teamwork from information technology, LIS, and I have to acknowledge also Anne from the lab. And the lab manager, Brandon. It was just an amazing teamwork. We figured out the logistics of how we will place the orders, how the algorithm of testing will look like, how we will trash specimens. So it was just amazing, and we were able to go live with the test March 11th. We worked closely, of course, with the infection control team. To also kind of try to establish those initial algorithms. And once we were live, we started with a capacity of 50, which actually increased to 500 and within thousands.
To clarify, that's per day.
Per day. And then to go back to the supply chain question, we actually anticipated this to happen early on, and we were proactive, and we were working on building the redundancy and validating additional assays from different companies. We also worked on different models, like we knew that we will need testing that should be run stat, and we knew that we would have to run large batches. So we offered the stat testing that can give turnaround time of 2 hours. And then we also ran those or develop those large batch kind of testing. So I think we ended up actually validating more than 13 different assays, and they were like going like we were going live like one after the other, like it was like 2 weeks apart. So we really worked together as a team in a very efficient way that I'm really very proud of, and really like sincerely acknowledging every single person who helped with this.
That's it. So the redundancy was so critical to the process.
It was definitely
Because
critical.
You never knew, and I remember there was one of the instruments that had a very specific type
plastic
or whatever,
Yeah.
and the supplies of that ran out.
Yeah,
How would you deal with that coming in one day and saying, all of a sudden, we can't use this instrument because this proprietary plastic tip isn't available?
Yeah, we just shifted volume to one instrument versus another. Yeah.
But you also discussed the 3D printing. Yes, I heard this question on the field.
Yeah, so it was incredible.
Yeah, it was a mix of supply chain issues from swaps to media,
transport
to
media.
plastics, to reagents, to like even transport and shipping. But very proudly to say we were never down in testing. Our testing was not interrupted at all for even one single day.
And I remember going down to microbiology, and there'd be these giant tanks full of tests that were being submitted to the lab. How many tests did you end up doing a day, and when did the testing really stabilize, where you felt you could sleep at night?
So I think we probably got to 2,500 samples per day at one point in the pandemic. And that was incredible to accommodate all of those swabs that came in. And I don't think testing really stabilized where we came off allocation until mid-2021.
I would say after the large Omicron,
we had the Delta surge, and then Omicron.
Right after that was when testing, and then after a few things changed, like the need to do extensive screening for pre-surgical screening, and then when at that time testing started to to stabilize, and the volumes started to be really manageable.
Right.
But in the beginning, the lab was like a factory. The mission is testing, increasing capacity of testing, and also offering the optimal turnaround time. So it was just amazing, and we were able to handle efficiently really up to 3,000 specimens per day.
Yeah.
And how did the staff and faculty feel? On one hand, they're in the trenches saving lives, quite literally. On the other hand, they have their own family stresses that they have to deal with, and their own fears of this virus that is circulating and is deadly, and they're coming to work.
Yeah. I mean, I have to say that our staff are truly amazing individuals. They just rose to the occasion. They worked with the faculty in the division. Everyone contributed in some way, either by actually verifying all of the platforms and all of the tests, or covering for those individuals so we could continue standard of care. The inordinate number of phone calls from irate, sometimes, staff. But they handled it all professionally. We knew that some people who had family members abroad, how stressful that time was. But they came to work. They kept themselves healthy. They followed our guidance for PPE. We had no in-lab transmission. Clearly, I can't be more proud or overstate how wonderful they are.
Heba, do you want to add anything to your thoughts?
I will also again take the chance to really acknowledge our team. They are very dedicated, and they were very engaged, and we worked as a team to build this efficient workflow. It was challenging for everyone, but I think the staff was very proud because they actually had the sense of the significance of what they have to offer not only for the institution, but also for for the whole state, for the community, because we also supported community testing and we supported other hospitals here, not only the Hopkins system. So for them, they were proud and they were really dedicated. But again, we were all challenged with the significant changes in our lifestyles, like masking and schools closing, and the international staff who had family members falling sick. But also, I'm very proud to say that our staff held strong and actually didn't get sick. So they took care of themselves, and even though we actually managed and handled thousands of samples. So I really give the credit to all our amazing staff.
And that sense of teamwork, that seems such a critical part of the response.
Yes.
Both within pathology and then pathology interacting with the other departments. Maybe can you expand a little bit on that?
Absolutely. So, Ralph, we were part of numerous teams throughout the hospital system, including supply chain, infection control. I remember there were weekly meetings, sometimes multiple meetings in a week with different groups of clinician users. I think also the other thing that I'm very proud about is after it was announced that we had testing available, as you know, you were contacted by other laboratorians throughout the state and even outside of the state to see if we could accommodate testing for some of the area hospitals, since LabCorp and Quest were not able to meet their needs. And the turnaround time at one point, I think, from Quest was as long as 2 weeks. Mm-hmm. So I'm very proud of the fact that we were able to assist, I believe it was about 10 different hospitals at one point. In addition to that, we worked with the GO team. This was a team of nurses and physicians who were out in the community, going to the homeless shelters, nursing homes, other community stand-up testing sites, such as in East Baltimore. In Highlandtown, I remember in particular, the Sacred Heart Church there had a huge testing site for the Hispanic population there in East Baltimore. So we were able to assist all of these groups, and it was very rewarding. And again, getting back to our staff who knew that we were doing this outreach, and they were very proud of the ability and their contributions to the community and to the state.
That speaks so beautifully to the Hopkins mission. It's serving our community, the poor and suffering, beyond the walls of Hopkins. How about you want to add anything?
I will actually also add to this that our staff and the lab was also central in supporting everybody's initial research on COVID. Mm-hmm. So we worked as a team to provide the specimens, provide data, facilitate testing for any research projects, and also we supported research and development when it comes to diagnostics with industry. We supported community testing and screening. We also supported the genomic surveillance, and this was another significant and market teamwork where my clinical staff and my research staff, we actually really worked together to set up the sequencing capacity, and this was also in collaboration with the state of Maryland, and we worked with the CDC. And I think our operation when it comes to genomic surveillance was really I think one of the very first, because we were able to sequence our very first positives. We actually had it ready. And across the Hopkins system, I also have to acknowledge all the labs across the system because they were supporting this initiative as well. So really amazing teamwork. So we not only supported diagnostics and larger scale diagnostics and the screening, we also supported research and we supported the genomic surveillance.
For those in the audience who don't understand what genomic surveillance is, so that's where you sequence the genetic code of the entire virus, and then look for new variants or kind
Correct.
of the evolution of
Yeah.
variants as they
Yeah.
come along?
Yeah, so we do sequence the whole genome, and we did it again with the very first positives. So we were able to see that we had diversity with our very first diagnosis. So we already knew that we had community transmission happening, and we had multiple introductions into the state or into the area, and then we were able to see and monitor the variants as they evolve. So we were able to see that even before, like globally, the initiative of defining variants of concern and alpha and the beta and so on, we actually were ahead of the game. So we had that data even before we were asked to support it like in an official way. So it was really amazing. And actually, by having this operation, we were also able to support multiple outbreak investigations for the institution and also for the university.
Yes. Karen, do you want to expand on the interactions with industry?
Sure. So we were very fortunate to have great working relationships with a lot of our industry partners. And so you've been to the lab, you see all of the automation that we have down there. And I think truly because we had such a variety of different types of platforms, this allowed us to have very early on the redundancy in testing because we had multiple partners that we can work with. So we already acknowledge Altona, who gave us our original primers and probes for our initial testing. And the dean helped us acquire the pneumatics platform. Luckily, that was a small company at the time, and a lot of people didn't know about the company, so we were able to, one of the first labs to get their instrument in lab, and they worked very strongly with us to ship the instrument and get that instrument online in a very, very quick period of time. And then the second instrument arrived, I think, 2 weeks later. So we were grateful to Dean Rothman because that platform, the pneumatics, turned out to be a huge workhorse for us. And then as we needed, to implement stat testing, Cepheid had worked with us early on too to help get their emergency use authorization. And then that platform we were able to help disseminate throughout the healthcare system to accommodate the stat testing in those environments. So I think we were very fortunate to have already some of these instruments in place, but also through our wonderful working relationships with these various companies to quickly acquire other platforms that we didn't already have. So Heba, I don't know if you...
But so it seems industry's going from pipetting things yourself, which you
Yes,
can't
right.
really scale up, to doing thousands of tests a day, to having
Right.
these automated instruments really allowed one to
Yes.
stabilize and expand. Is that accurate?
Yeah, exactly. And so those first 2 weeks after we went live until we had our first fully automated instrument, where we were actually hoping to increase the capacity of testing in these 2 weeks. This was actually when we needed additional capacity for that manual process. And this was when Dr. Chris Buki and his team stepped in to offer that capacity in their genomics lab. So I think another example of teamwork.
Yes.
And where we had this operation extending to other places in the department. But yes, automation then helped us streamline the process and process way more samples and a more efficient workflow. And again, we had that redundancy and multiple instruments from multiple companies.
And you alluded, we have a tripartite mission: patient care, education, research, and you alluded to that the need to understand the virus better and its interactions. Can you maybe highlight one or two research accomplishments that from the pandemic?
Yes. So again, another teamwork and collaborative effort. So we really built a really nice pipeline of research where we characterize the viral variants and their change almost in real time. and then we coordinate this or associate the findings with the clinical presentations, and then we take this downstream to basic research and the cell culture work. So my close collaborators have been Dr. Eli Klein, he's actually in the ED, and then Dr. Andy Bekush from Bloomberg. And we really published a lot of papers to describing the early introductions, alpha to beta to delta to Omicron. What did the surge of Omicron mean? The Delta wave, and how the Delta was actually associated with more severe outcomes, especially for inpatients. And we had additional collaborators outside of this circle, so we actually were able to integrate the thousands of genomes that we generated into what is called the JH Crown, which is the database that Hopkins actually tried to put together for the clinical data for research. So our data actually is contributed and was added there. So really many findings and a lot of research we were actually able to generate as a part of this operation. And this actually was expanded now to additional questions and additional pathogens. So it was actually a very nice infrastructure to build on. So really amazing, and I'm still very proud of all the collaborative efforts across Hopkins.
Yeah, it truly is amazing. But I think there was some more mundane type of clinical research too. Like we, like the whole saliva testing lab, that was set up by Chris Goki. I mean, we were able to compare saliva to oropharyngeal swabs or nasopharyngeal swabs. We published our validations for some of the platforms that we brought in collaboration with other centers. We had to do a lot of validations of transport media, swab materials. So the research was both practical as well as basic, and was very helpful in meeting some of the challenges for mass testing as well.
And also in that very first phase of uncertainty, when providers didn't really know how to interpret a lot of the testing, if it's false negative or false positive, prolonged chilling, CT values. So we were actually able to also do our best to understand the utility of the diagnostics, and also to try to support that clinical interpretation.
Fantastic. So the really true tripartite mission. So how many tests have you done to date? And
I don't think we know the exact number. We know it's well over 1 million.
Yeah, and this is excluding the saliva testing that I think also over 1 million.
Yeah. How many lives have been touched through the testing?
It's incredible.
It's just amazing. So, Karen Heba, obviously when the vaccination was such a critical part of the response to the pandemic, can you give us some details about that?
I think the rollout of vaccination was actually remarkably quick as well. But I have to acknowledge the institution for supporting the early vaccination for the healthcare workers. And I still remember actually our very first a staff member to get vaccinated. Craig, actually, we took the pictures because it was a historical moment, and this was December 2020. So this was the time when we felt like there is light at the end of the tunnel, and that there is hope that we can see each other's faces again. So it was a very organized way to vaccinate all the staff, and I think Hopkins did a fantastic job in implementing the vaccination and operating the vaccination very quickly.
I agree. I'm very grateful that our laboratory staff were seen as essential workers and were able to get into the early lottery to get the vaccine. I'm very, very appreciative of that.
Yeah, thanks. And you've described central testing, but there's also point of care testing, meaning out at the site where the patients are. Can you give us some details about how point-of-care testing was developed and the impact that it had.
Yeah. It was actually a good chance that COVID pushed this a little bit forward, because it's an initiative that actually Dr. Karen Carroll has always been interested in, and she was working with Dr. Bill Clark and Jean to get this really and also the ED team for a while. But our first molecular point of care testing was offered in labor and delivery. This was the very first. And really, Dr. Carroll put a lot of effort into this. And then we expanded to offer testing in the ED and in the other Hopkins hospitals EDs. So this really helped with the turnaround time for specific population of patients. So I think this is another accomplishments that we had out of this pandemic. And then the antigen testing that was also offered, and also under the supervision of Dr. Bill Clark and Regine and their point of care testing team. So this was really instrumental in operating a lot of like moving parts during the pandemic, including like surgery and triaging patients and so on.
So you mentioned labor and delivery. I can just imagine the impact that would have. A woman pregnant, she's about to give birth, and and not knowing whether she had COVID-19 or not, would have been for the healthcare workers in the area and for the health of the mother and the child very significant.
Yeah.
So I can see the impact of point of care testing then.
Yeah, Dr. Sheffield deserves a lot of credit, because we reached out to her. There was an issue with trying to get the swabs down to the lab in time before the woman delivered, and there was so busy up there, and so when I reached out to her and said, Dr. Mustafa has evaluated this little point of care platform called Acula. Would you like to implement that in labor and delivery? And she said yes. And they owned it. I'm really proud of them. They worked very closely with myself and Jean Mumford to implement it, and they did it safely, and they did it for quite some time. So it was a nice experience in terms of the fact that it could be done, and that was very exciting.
So what's your proudest moment?
There are a lot of proud moments. So, I think obviously when we were able to launch the first test, I was really incredibly proud of, the molecular team and the lab in and of itself when we first started getting samples that we could actually test on site. So that was very wonderful for me, and I think for the lab as well. And the other proud moments, and I've never had this experience, is that people who didn't even know me would stop me in the hallway. I'm really grateful, because I would just make this announcement that when I went back to the lab, like Dr. So-and-so just stopped me and just wanted me to thank all of you for, the testing and how quickly you rolled it out, and it's had an immeasurable impact on patient care. So please, convey that message to your team, which I was, of course, happy to do. We had a few luncheons, too, that were celebratory. And then, of course, when the dean gave us the award, that was lovely.
What about you? Your proudest moment?
I think there are so many, but I think the proudest was when we were live and when we tested our first specimens and we diagnosed our first positives.
Now, what about the flip side? Your most fearful moment, when you were most afraid?
I also have so many.
I do too.
It will actually sound funny, but the one that stands the most was when the international travel was banned. And I was so afraid that we will not be able to have the PCR reagents from Germany. So I think so far this was maybe because it was also in the beginning and it was the hectic time, and I was so scared. But luckily they did it. They were still shipping reagents, so we were able to receive the reagents.
Fantastic. And what about you?
So I think in the early days, I was very fearful for our staff and for our patients. For our patients, because I didn't know if we were going to be able to do testing. And there was a lot of anxiety around that for almost the entire month of February. And then I was worried because we weren't really 100% sure of whether the virus could be transmitted in the laboratory. And so I do remember having a huddle. We had a huddle in the office with Brandon and I believe Heather, you were there, and with our processing staff. And we just said, okay, this is what we're going to do for any respiratory sample. And we outlined the PPE that we were going to use. And I said, my first duty is to keep all of you safe. And so please mask, double glove, keep the gowns on, wear goggles and face shields, work within the hood for any respiratory sample. So that was something that I really wanted to ensure the safety of our individuals. And we did that actually before the mandatory masking policy. When the CDC refused us, I was very fearful, were we going to be able to meet the demand? And then the third fearful moment, and I have to tell this anecdotal story because it relates to what Heba just said about our pneumatic shipment from Germany was delayed. And it was also around the same time that the plastics for our automated instrument was also non-existent. And so at that point we were testing over 1,000 samples per day. And I remember that we were really very close to running out of sample of reagents for the pneumatics. And we couldn't really resort back to doing manual testing without the automated extractor. So I remember that the loading dock texted Heba to say that the reagents for the pneumatics had arrived, but they couldn't find them. So the three of us, Heba, Brandon, and I, were running down the hallway to the loading dock to look for them ourselves, because literally by the next day we would have been out of reagents. Luckily, they found them. And so I almost collapsed with relief at that point because we just did not have, a backup, because Quest was still not able to meet, the testing demands. And so we didn't really have any other options. But that was another fearful moment. Luckily, that resolved. But
is there anything I've missed? Anything you'd like to add?
I think it was an amazing experience, and it was very stressful and concerning. But I think it brought the very best in every single person in the lab. Very amazing moments, stressful moments, but very the true collaborative teamwork was really what actually is what stands the most for me right now when I think back. I think about how we can actually come together to make this work in such a challenging time. I feel like the lab supported the Hopkins institution, the whole state, the community. I think our contributions were significant, and all our staff, and we are very proud. I think if this is to happen again, which I hope not very soon, we will be ready, and I think we are ready to stand again in a stronger manner. I think I would like to end by really thanking every single person who have helped us. There are so many, and I'm sorry if I missed acknowledging anyone in person, because there are really so many. So thank you, everybody, and Yeah.
And Heba, we should add, you were actually pretty new to the job.
I knew.
Right? This
It's a baptism by
out
fire.
of training, you came. This was your first job. How long were you on the faculty?
6 months.
6 months. Yes, it was very, very fortunate that she was here. I mean, just to echo, I have to say, likewise, I'm not only proud of, our laboratory, but our department. And I felt very much supported through the whole pandemic by you, Ralph, and also our colleagues. And again, I want to mention Bill Clark, Jean Munford, Chris Goki, Al Valentine. Oh my gosh, poor Al. And Brandon. It was wonderful that Brandon and Al set up the weekly calls with the affiliates. I think that was very helpful. We didn't even mention antibody testing, how incredible that was. The immunology lab standing that up, because that contributed to healthcare worker study that actually just ended not too long ago. So Dr. Cataregli's antibody testing, and I think that helped inform response to vaccine. And I'm just very grateful for Heba, all of the people in the lab, and for the department for the support. Particularly during some very difficult times. I really do appreciate that.
Yeah.
Well, Karen, Heba, we thank you. The institution thanks you, and our patients thank you. You should be proud, and your team should be proud. So thank you very much, and thank you for spending the time with us this morning. Really appreciate it.
You're welcome. Thank you.